are they, them, and theirs. Tonight, I'll be your moderator for this conversation, and I'm coming to you by way of Equality, North Carolina, where I currently serve as the Director of Education Policy. Joined with me is my lovely dog barking outside, as well as the summer cicadas. So thanks for welcoming them into the conversation as well. I'm a biracial, non-binary person wearing a white button-up with blue floral print, and I have short, curly hair. And before we begin, I have a few housekeeping tips to share with you to ensure that everybody can participate fully in this webinar. To view our closed captioning, you'll see a closed caption or a CC button at the bottom of your screen. Please select that where you can show subtitles. Tonight's event is a webinar, and participants will not have access to turning on your own camera or unmuting yourselves. However, we do have a Q&A box, and I'll talk about in a moment. The chat box will be live where you can communicate with us regards to any access concerns that you're facing or any technical support that you might need. If you need additional assistance, please select host/panelist and type your comment in that chat box, and that will go directly to the team who's helping make tonight's webinar possible. You might have a lot of questions while we're here together tonight. The question and answers box at the bottom of your screen is where you can type any of those questions, and we'll have a Q&A section towards the second half of our conversation where we will welcome all of those questions in and do our very best to get to all of them. Your questions will be read out loud and they will be answered live. I just want to acknowledge the ASL interpreters here. Thank you so much for interpreting tonight, as well as for our captioning teams and everybody here. You can see our interpreter is here. They'll be switching back and forth. And then we do have our captioning person who will be providing those captions for us. There will be a link where you can see the captions in another window, and I believe that will be dropped in the chat. Yes, that's in the chat for you already. You've heard enough from me. We have some incredible folks here tonight to help us join in on this conversation. Secretary Kinsley, I'd love to pass over to you to say hello to the folks in the room tonight.
Thank you so much, Rebby. I really appreciate the opportunity for us all to be together tonight to have an important conversation about the monkeypox virus, what we know, what we're still learning, and how as a community we can all work together to get checked, to get tested, and to get protected. So I hope that you will bring your questions openly, and I look forward to this conversation. It is my great pleasure to serve as the Secretary of Health and Human Services and to serve the state that I grew up in. I'm particularly grateful for Equality NC for moving as quickly as they did to bring this together. It is, I remember participating in Equality NC's lobby days 20 years ago. And so it is really wonderful to come full circle and to still have such an amazing partner and leader in an organization as them. So it is wonderful. Thank you, Rebby.
Thank you, Secretary. It's a pleasure to see things come full circle. We have another incredible panelist here tonight with a wealth of information I know I will learn from tonight as well. Dr. Mobley, would you love to come on and say hello to our folks?
Absolutely. Hey, good evening, all. Thank you so much for joining this town hall. I am Dr. Victoria Mobley, and I am an infectious disease physician and a medical consultant for the North Carolina Department of Health and Human Services. And for the last several weeks, I have been assisting in our state's response to the growing monkeypox outbreak. And so I'm extremely glad to be on this call tonight with you, particularly to talk through some concerning trends we're seeing nationwide and in North Carolina, and to answer any questions you might have about how to protect yourselves and your family and your communities. But I do want to take just a few minutes before I turn it back over to Rebby to give a little bit of context, particularly about the virus, and give just a quick overview of this virus. So this is not a new virus. This virus has been around for a while. It's not like COVID that came out of nowhere and knocked us out and we had to learn on the go. This virus was first discovered in the 1950s when it caused a pox-like illness in some research monkeys, hence the very unfortunate naming of this virus. That's how it got its name, no other reason. The first case was reported in humans, was reported in the 1970s in the DRC. And since that time, there have been frequent outbreaks in several West and Central African countries where the disease has essentially become endemic. There have been some isolated cases reported outside of endemic countries in the past, but those were mainly associated with travel to and from endemic countries, or in the case of the 2003 US outbreak, exposure to infected animals that were acquired as pets. So the monkeypox virus is in the same family as smallpox. It causes a similar in appearance illness, but is a much milder disease. And there are two types or clades of monkeypox virus. And fortunately for us, the clade that's causing this outbreak has a really low mortality rate, so less than 1%. So although monkeypox is an illness none of us want to get, it can be very painful, it can have a prolonged course. The majority of folks, it's going to be self-limited and it's going to resolve in 2 to 4 weeks. So with that, I'm going to give you just a quick snapshot of where we are with case counts globally, internationally, and then in North Carolina. So as of this, probably as of last afternoon, globally, there were 20,804 monkeypox cases in countries that don't typically see monkeypox, so non-endemic countries. 71 countries cover those 20,000 cases. In the US, there were 4,639 cases. And in North Carolina, as of this morning, we have 46 cases. I'm going to turn it back over to you, Ravi, and we can get started.
Dr. Mobley, thank you for that overview. It's really important for folks in the room to sit with that for a moment, that this is not new. It is an unfortunate name, and where we're headed with it is also an opportunity to look back at where we've been as a way to move forward. There's a lot of information online, in conversation, in the news and media. So the goal of tonight's conversation is to go a bit deeper and to help answer the questions that y'all might have about the virus, as well as helping to dispel some of the myths that we're seeing in media and beyond. So let's get right into it. Dr. Mobley, please share with us, how is monkeypox transmitted? You talked about earlier cases in the 70s, and are we still seeing similar transmission today?
So the transmission mechanism hasn't changed. The main mechanism of transmission for this virus is close or intimate skin-to-skin contact with the rash or sores or body fluid from someone with monkeypox. So this can occur with everyday activities that we all engage in, like hugging and kissing and cuddling and having sex. And because this virus is a hardy one, it can survive outside the body on inanimate objects, or what we call fomites, which means that it can also be transmitted with the sharing of those. And this typically occurs with linens, with towels, and clothing that have come into contact with the rash or sores from someone with monkeypox, and then is shared with someone else prior to it being appropriately laundered. And then the less common transmission mechanism is through respiratory secretion. So things that generate respiratory secretions like coughing and sneezing can spread monkeypox, but typically this requires face-to-face contact, so 2 feet for prolonged periods of time. And so the standard precautions that we're still taking now because of COVID, like wearing a mask in public and standing 6 feet behind or away from someone else, are great prevention measures for monkeypox also.
Thank you for that overview. Secretary Kinsley, anything to add to that in this moment?
I'll just add that, what has been interesting about this outbreak, because it, requires that prolonged, close skin-to-skin contact, we see this social network phenomenon playing out, where it is really taken hold at this moment, primarily in men who have sex with men. And I know we'll talk more about language and messaging. I think that really is important here in a moment. And, in North Carolina, the cases that Dr. Mobley mentioned, nearly all of them are in that group. And we are sharing that because we want folks to know about kind of the current impact of the virus to make sure folks have the information they need to protect themselves.
Thank you both for all of that information. We'll be continuing to dive in. I do see some questions are starting to show up in the Q&A. Thank you for those. We'll be getting to those here in just a little bit. If you are putting your questions in the chat, please take a moment to copy them over into the Q&A, and that will help with the moderation of the Q&A portion. So let's talk about some of the signs and symptoms of monkeypox. I grew up being really familiar with chickenpox and the visual manifestations. And talk to us about how we can see those symptoms, feel those symptoms. What should we be looking for? Dr. Mobley.
Absolutely. So I will put up front that although monkeypox in appearance can be mistaken for chickenpox, they are not in the same family of virus. So having had chickenpox and recovered or having had the chickenpox vaccine does not confer protection against monkeypox. But for monkeypox, so what are we looking for? So the incubation period for this virus, and the incubation period is the time from when you're exposed to when you first develop symptoms, can be anywhere up to 21 days. Typically, folks will start to have symptoms around 6 to 13 days after their exposure, and those symptoms generally start with a flu-like illness, so fever, headache, muscle aches, general fatigue, just feeling kind of pooped out. A significant proportion of individuals will experience swollen lymph nodes, whether that be in isolated, areas or all over the body. That's another characteristic of monkeypox illness. And then after that flu-like illness, 1 to 3 days later is when the rash typically appears. And from all of the many years that we've known about monkeypox, it typically appears on the face. You can have lesions in your mouth, and on the extremities is where it's predominantly seen. I'm going to talk a little bit about what we're seeing in this outbreak that differs from that. But the rash itself, no matter where it starts, it follows a progression. So it starts first as this flat kind of macular lesion, and then it progresses to bumps, and then it progresses to fluid-filled blisters, and then to pus-filled blisters, which can have a central area, a dimple, we call it umbilication. And after that, it'll start to scab over and dry up. And that whole process can take 2 to 4 weeks. And a person is considered infectious until from the time that their initial symptoms start, so whether that be the flu-like illness or the rash, until their scabs have all fallen off and there's a fresh layer of skin under them. Now, for this outbreak, we're seeing something a little bit different. So let's talk about that, because it's I think that's part of the reason why earlier on it wasn't identified by providers, because this is not what they typically associate with monkeypox or pox-like illnesses. We have seen in this virus, in this outbreak, that a significant proportion of folks are not presenting with the flu-like illness initially. They're at all or before the rash starts. So no flu-like illness, no fever. Their rash can be isolated to the genital region or the perianal region. It may just stay there with a few lesions, or it may start there and spread out from those locations, which is not typical of this, of monkeypox, or what we know of monkeypox from previous outbreaks. And the lesions can also be internal. So they can be in places where you don't easily visualize them, but cause significant pain and out of proportion to what providers would normally put on their differential for causing, say, a pharyngitis if the lesions are in the mouth or the throat, or causing a proctitis if the lesions are in the anus. So it's really important for providers and patients to consider whether or not monkeypox is playing a role in the clinical symptoms that are presenting, even if they're not typical for what we generally think of with monkeypox.
And thank you for naming all of that. There have been conversations as well of some of the external lesions and bumps almost looking like herpes in a way. Secretary Kinsley, happy to hear from you as well of what we're seeing on the ground and how folks might be responding or even confusing some of the symptoms with something else.
We know, early on, as folks were, especially in our healthcare provider space, were really, recognizing these changes, that we weren't having as much folks referred for testing as we would like. One of the things that we really want to remind everyone, and there's actually a kind of a healthcare provider webinar that's happening right now as well with healthcare providers across the state, is we're showing the signs and symptoms of this virus so that our healthcare providers can really be on the lookout and make use of what is ample testing available. Our state public health lab has actually had the ability to test for this class of viruses for years. North Carolina's public health lab is a leader in the nation in having that capability, and it's incredibly well resourced in that way. But the other great news is that, as Dr. Mobley said, we're dealing with a virus that we know it's not new. And so we saw that our commercial labs across the country were able to step up quickly and increase their capacity as well. And now we see a capacity of upwards of 80,000 tests a week that can be done across our commercial labs. And we're nowhere near using that capacity. And so we continue to have encourage providers to be on the lookout. And as Dr. Mobley, suggested, these can begin to look like a lot of different things, and which is why it matters to get it swabbed and tested. And so we continue to encourage testing to make sure that we can really know what's going on.
Outside of my own medical provider, I've noticed I've been able to have access to COVID testing, for example, at CVS, Walgreens, even pop-up clinics that are offered in my local area. I'm curious where folks can turn to first to have some of this testing done, knowing that there's a large capacity to offer that.
So maybe I'll start and turn it over to Dr. Mobley, who will have some clinician thoughts that will be helpful, I'm sure. So right now, your healthcare provider, if you have a primary care provider, is a good place to start. They have connections to our lab, they have connections to commercial labs, and they can send out those things for testing. Of course, there's another alternative, which is calling your local health department in your county or your region. They also have the ability to provide testing for this. Because it can masquerade as many things, that clinical assessment matters. And so that's why, this disease, different from a sort of do-it-yourself nasal swab, is not as easily kind of popped up in a lot of different places. I'll tell you that we're really trying to think hard about how to increase access and what could simplify the process, but without losing that important clinical assessment and conversations. Because if you have a series of dimpled bumps in a region of your body and it's not monkeypox, we probably still want to figure out what's going on. And so we want to take it a step further, and that's why the clinician's important. And speaking of the clinician, let me turn it over to Dr. Mobley.
Yeah, both Secretary Kinsley and Rebby have brought up a really good point that I do want to touch on, which is monkeypox can happen in kind of a context of other things happening as well, right? So just because you have monkeypox doesn't mean you can't have another infection. And so going to the clinician is extremely important. And monkeypox can look like a lot of things, which I think, Rebby touched on, which is, there's certain stages of the monkeypox rash that can look just like herpes. It can look like symptomatic syphilis, with lesions on the palms and the soles. So, and we've seen co-infection and folks having both monkeypox and HSV, or monkeypox and syphilis, or monkeypox and other infections. So it's really important to get checked out by your clinician to make sure that even if you do have monkeypox, that's not the only thing going on. And then to get the testing, which, it is true that, it's easy now to do the nasal swab for COVID, but the monkeypox lesions can be quite painful. And to get a good specimen where you increase the likelihood of getting an accurate result, you really have to swab those lesions in a way that's uncomfortable and most folks probably wouldn't want to do for themselves. And then on top of that, it still needs to be packaged up appropriately and sent to an appropriate lab for testing. So that's why you need to involve your clinical providers. And if you don't have one, calling your local health department, they can definitely help link you to testing in their facility or in a facility in your community near you.
Thank you both for that in-depth conversation. And if y'all haven't already taken a peek at the North Carolina DHHS website, what we're saying is also reiterated, and you can continue to access these resources, and we can likely paste something in the chat for folks to take with them from here. I appreciate all of the questions that are coming into the Q&A. Just a reminder, if you are putting those in the chat, they might get lost. So please pop over to the Q&A button at the bottom of your screen. We'll be getting to that momentarily. We talked about testing. We talked about symptoms. The moment to interpreters to switch. Yeah, I see y'all. And I'm curious about vaccinations. We've been talking about vaccinations for quite some time now. Talk to us about what we can expect, what rollout looks like. How do I find out if I'm eligible for a vaccine against monkeypox? Dr. Mobley, we'll start with you.
Okay, well, I'll take on the, so who should consider getting vaccinated. The first group are individuals who have had closer intimate skin-to-skin contact with someone with monkeypox in the preceding 14 days. So if you get vaccinated within the 4 days after your exposure, the vaccine may actually prevent illness altogether from developing. And even if it's not within that first 4 days, if given within the 14 days after exposure, it can significantly reduce the risk of developing severe illness should you become infected. So anyone meeting that criteria of having had contact with someone with monkeypox in the past 14 days should really call your provider, call your local health department, and try to get your monkeypox post-exposure vaccine. And individuals who are at risk for developing severe illness are those who are have an immunocompromising condition, pregnant women, and young children. So again, if you're in that group, you really are the main priority targets that we want to get vaccinated as soon as possible after your exposure.
Additional thoughts, Secretary? Thank you. There are quite a few, and this is Rebby, and there are quite a few questions that have come up. So I'd love to move in that direction. If we can bring both Secretary and Dr. Mobley to the front of screen, we'll be passing around the baton here a bit quickly. And in looking at a few of the questions, again, I'll be reading each of these out loud. If we find that we've already addressed your question, we might just acknowledge that. So starting here, we have a comment from Greg. I live in Hanover County and was told to get on the waiting list in Mecklenburg County to get the vaccine. I did get online to get the Mecklenburg County waiting list. Is that the best that I can do for now?
So, Rebby, I can jump in if that's okay.
Yeah, go for it, Secretary. Thank
sorry,
you.
I didn't mean to jump in. So great question. Right now, vaccine supply is relatively limited. The federal government had a supply, first off, maybe back up. Similar to the context that this is a known disease, we're in such a phenomenal place because we have an effective vaccine available. The federal government had a supply of that vaccine in something called the Strategic National Stockpile that they held. They had a very small amount of it here in the United States because they were really planning for a very small smallpox outbreak. And they had a much larger portion of it in Denmark. And so they had been essentially ordering that and pulling it out of ultra cold storage and getting it here in tranches. And then they went to some of the plants that have to do work to bottle the vaccine, to clear them and approve them to do that work and get more vaccine here. So it has been a bit of a logistics challenge and for the federal government to work to do that. And North Carolina has been getting a portion of those allocations as they have come over. We have gotten to date a couple thousand or several thousand courses. And early, when the supply was very small, our first allocation was 444 doses. We allocated it out to essentially a handful of local health departments to create a regional access point so that folks could either go there or we could work to get that vaccine from that local health department to your closest local health department to do that. As supply continues to increase, our goal is to increase those access points to make it easier. And we're working with our local health departments to leverage tools like waiting lists and tools that we're all familiar with from COVID, sign up geniuses, other things to kind of get those appointments moving. Right now, reaching out to your closest health department or the list that we have on our website of where the vaccine is the right place to start. Again, I hope that we'll be increasing access soon so we can get more closer to you and get folks through. And we continue to work with the health departments to try to improve and optimize their operations so that they can get folks vaccinated as quickly as possible.
Any additions, Dr. Mobley?
I think this might be a good time to briefly talk about what Secretary Kinsley is referring to, which is pre-exposure prophylaxis. So we talked about folks who have come into contact with someone with monkeypox getting post-exposure prophylaxis, but the next priority group and a close priority after that initial group are individuals who are at higher risk for monkeypox because it is disproportionately impacting the communities of which they're a part of. And at this time, as he mentioned earlier during this webinar, in North Carolina, the community and population being disproportionately impacted by monkeypox are gay, bisexual, and other men who have sex with men, and especially communities of color. And so for that population, while we have limited vaccine, we really want to prioritize getting vaccine out to those communities. And we have put our vaccination eligibility criteria out there. We appreciate everybody who's calling and getting on wait lists. I'm so sorry that there are wait lists while we're waiting for our next allotment from the CDC, but really want you to talk to your provider about your risk and whether or not you would benefit from a monkeypox vaccine, pre-exposure prophylaxis vaccine, and make sure that if you and your healthcare provider feel that is something that you would benefit from, that you look on our website, find a vaccine site, and reach out and get your appointment scheduled.
Thank you for that. And I'd like to move to another question, which is a big question for tonight's conversation, is acknowledging the rates in our state of the folks who have reported cases of monkeypox, and that overlap of acknowledging queer and trans folks within the LGBTQ community, particularly those of color. I'd love to just take a moment here and hear from both of y'all and what we're seeing messaging wise, what our numbers look like, and really dispelling that this is not an STI, this is not an STD. As you've named, monkeypox can be spread with close contact. I'd love for just to hear from both of y'all a little bit on that.
Thank you. Getting the messaging right here is really important. As I think we're all seeing as we talk about this, there are a lot of complexities. First and foremost, full stop, this is not an STI. Right? This spreads by close, intimate skin-to-skin contact. Right? It can spread during sexual activities and during non-sexual activities. And I think that's very important for us to underscore. Second is, because this virus requires that sort of close, intimate contact for spreading, when it starts to take hold in a particular cohort, we see it hold in that cohort over time. And we have, a lot of intimate, close contact happening in the men who have sex with men community. I think a couple things here. One is we feel it's really important to talk about, men who have sex with men. We haven't wanted to use particular identities. It's not every, would feel like they would identify in a particular way. We're talking about that particular activity where we see it happening. And the other aspect of it is that we think it's really important to be clear that while anyone can get it, the data is showing right now where it is actively happening. And as we have limited vaccine, we really want to make sure that those folks who are most at risk where things are spreading, that they have access to that limited resource. So, I think it's really important that we lead with the data here and that we're transparent about it. But I want to acknowledge that this is not a gay disease, right? Viruses don't have a preference in kind of different communities in that way. This is, I see, a health disparity. We've got a particular community of folk that are burdened by a disease disproportionately from other communities. And that is nothing about those individuals and everything about our healthcare system, our support of individuals that are in that space. And, our focus at the department and working with healthcare providers across the state is to make sure we can wrap the right prevention supports in the way of vaccines and other services and supports and access to testing around those individuals to serve them to really achieve a fair outcome, right? We want to see no one with monkeypox, right? Right now, we have a disproportionate outcome where only certain groups are ending up. We want to solve that and achieve a fair outcome of no one with monkeypox.
Any additions there, Dr. Mobley?
No, he touched on everything. Thank you.
Of course. And Dr. Tanya Bass also has a comment here about recognizing how folks who have active cases, how they're being seen, and how that support looks like in North Carolina without further stigmatizing LGBTQ folks, and knowing that there are already some barriers of equitable access in our state. And would you both or one of y'all mind to speak to Dr. Bass's comment?
Well, first off, I'm really happy that Dr. Bass is here and is a wonderful partner in the state and does phenomenal work, and can really talk the talk and walk the walk in what we aspire for all of our providers, which is providing culturally competent care that doesn't further stigmatize or create shame around normal parts of life. And those are core parts of our mission always, and things that we're trying to do here. And I believe that, us tackling this head on and being very transparent that there is no shame in being sick and there is no shame in sex is an important thing for us to do, and for the folks to hear from us as well. And that's what we're tackling. I will acknowledge that, unfortunately, and this is based off national data, individuals in the LGBTIQ plus community are more likely to be uninsured. North Carolina, as you know, has 13% of its population without access to health insurance. So we're likely to see individuals in this community to be disproportionately uninsured compared to others, which creates real challenges for us. That means that people won't already have a primary care provider or a connection with a healthcare provider. And it also means they may not have really confidence or comfort in navigating a health system, which is why the task is really up for us to make sure that our health departments and other providers are ready. And we continue to advocate with the federal government for funding to try to support more access that we think is really important, especially right now.
Additional thoughts, Dr. Mobley?
No, I completely agree with Secretary Kinsley.
Yeah. And Dr. Mobley, while I have you, there are some additional questions that are a bit more specific on how to handle symptoms, understand symptoms, and how to take care of ourselves at this level. So there was one specifically about the concern about folks that might be in group homes and thinking about laundering. And this conversation came up very early on during the early COVID outbreak. So if clothing is being washed, should we be separating our clothing that might have come across lesion skin? Will you talk to us a little bit about the best way to launder?
So the IP recommendations for dealing with potentially contaminated linens and bedding and clothing isn't really different from normal. But the main point here is just if you're known to have monkeypox, or you have a new rash and an unexplained rash that could be, don't share items between individuals. So laundering completely, and hot wash and then hot dryer is completely appropriate. But just it's the sharing of the items before the appropriate laundering that's the concern for transmission. And then, sorry, let me just, because, ID doc, I have to say this, frequent hand washing is important. So, we touch our skin a lot when we have rashes that itch or hurt, we touch the lesions. And so, you can transmit the virus to your fingers, and you can transmit it to other parts of your body that, could put you at risk for even worse symptoms, like if you touch your eye and ended up with a conjunctivitis. So frequent hand washing is always good for any infection prevention purpose, and in this case as well.
Thank you for naming that. Additionally, you named that there's a fatality rate under 1% mortality rate. And there was a question here specifically about if monkeypox can cause death. And would the vaccine prevent somebody from getting the disease?
Yes, monkeypox can cause mortality, but it's very rare, and it's usually seen in individuals with other underlying medical conditions that predispose them to severe illness. The vaccine can prevent illness from developing at all if given within 4 days of exposure. It's not 100% that it'll prevent illness, but if given in that quick window after you've been exposed, it can prevent you from developing infection at all. But beyond that, if given within the first 14 days after exposure, even if you get infection, it will decrease the severity of illness. And that's, that story we've been hearing over and over again with COVID, right? So, COVID vaccine can help prevent infection, but if you get infected, the ultimate goal is to prevent severity of illness and morbidity associated with infection. And that's the same case with the monkeypox vaccine.
Thank you for naming that. And another person asks, I've had COVID twice since September 2021. Would that consider me to be immunocompromised?
Yeah, there's no easy answer for that. I think you could probably talk to your provider about, to review your medical history to see if you have an underlying immunocompromising condition. But as we know with COVID, it's just really infectious. I have friends and family that have been infected 3-4 times since this pandemic started. And, and I know that they don't have any underlying immunocompromising condition. It's just COVID is that infectious.
Thank you for those responses. So there's a piece here. Joel asks, I've received conflicting information on how long I have natural immunity after recovering from MPV, or the shorthand for monkeypox virus. What's the latest data here? I appreciate that there's a limited vaccine supply and that there are people who need it, but wondering how the vaccine will be available more widely later.
So it sounds like you might be talking about if you've recovered from monkeypox, how long do the antibodies you produce protect you? And so the short answer is we don't know. You likely do have protection for an amount of time, which is unknown. Just because the data that we have is coming from countries where there weren't a lot of resources, and so there wasn't a lot of research that was captured. A lot of that information is probably going to come out of this outbreak, the global and U.S. outbreak that we're experiencing right now. We're going to learn a lot about monkeypox immunity after infection, about how long the Jynneos vaccine lasts, both first and second dose, how long that immunity lasts. So unfortunately, I can't give you a great answer, but hopefully in the future, we will know more.
And a similar question is, if somebody has a smallpox, if they've been vaccinated against smallpox, would that help them in preventing transmission of this current virus?
It probably provides some protection from getting monkeypox, but depending on how long ago you got vaccinated, which for most folks, you're going to be over the age of 40 or 50 if you were vaccinated for smallpox. There could be waning protection. So if you're in one of the risk groups, if you're exposed to monkeypox, you should get the Jynneos vaccine. And if you're in one of the risk groups where we're seeing increased transmission of monkeypox, you should also consider getting the monkeypox vaccine.
Thank you for that. Secretary Kinsley, I'd love to bring you back to the front here, as we've had a couple questions. One about how is the North Carolina Department of Health and Human Services doing work around messaging for folks that might be most at risk for contracting the virus. And there are a couple follow-up questions as well, but really curious, what are y'all seeing behind the scenes right now?
So, it's really important that we get the message out, which is why we want to have conversations like this and partner with local community-based organizations to continue to spread, the information about where we're seeing the virus currently have the most impact. I will say from the data, we have again seen nearly all cases in men who have sex with men. Nationally, we've seen some increases among trans women and transgender individuals, but that data hasn't been incredibly firm. And so I've wanted to be very careful about exactly what we're seeing and being very transparent about that. The other piece of this I want to touch on briefly is that, from a variety of studies that have done and a lot of the international data we have coming out of the UK, is that the current prevalence in this community is not simply because of under-testing in other communities. We see testing happening in those communities and their rates being incredibly low. And we know so all to say that it's important that folks know how it spreads, close skin-to-skin contact. It's important that folks know that through skin-to-skin contact, not necessarily sexual contact, individuals could get this disease, but that right now it is spreading primarily in the men who have sex with men community. And I hope that all of you, there's 133 folks on right now, will help us really amplify this message and encourage folks to be on the lookout, to get checked if they see the signs or symptoms, as Dr. Mobley was talking about, to also get tested. Their providers can help make that possible. And then if they're either someone who was exposed, could be anyone, or if they're in the priority population that we're talking about right now, to get vaccinated and to seek that out as an effort to protect themselves. So we will continue to amplify this work. We have been working very quickly to establish ad campaigns and to partner with key outlets, reaching out to various applications and various other spaces, community centers, different groups, to try to help get the word out for folks to take this up. And again, I want to really amplify the other key aspect that Dr. Mobley mentioned, which is we are seeing right now, and again, our case levels are relatively small. And so I always want to make sure, we don't have a large enough number to kind of be overly confident, but we are seeing a disproportionate number in Black men in particular in North Carolina, out of pace with what the population is. And so I particularly want to make sure those individuals know about the risks that we're seeing right now.
There is an additional comment as well, a question really of ensuring that these steps are being taken broadly to serve those who have been systemically marginalized, as we think about those underserved, Black and Latino folks, thinking about same gender loving folks, LGBTQ folks, as well as those who might be living in rural areas. And I just want to honor and underscore that all of those efforts and moving in that direction. And something I want to really name, and as we have discussed throughout work in the state and broadly speaking, MSM historically has created some harm in the way that we think about the representation of transgender, non-binary, and gender non-conforming people. And I've seen this show up in the question box today, and I just want to underscore that, as MSM might be a term that is used widely, we know that the limitations is it often excludes trans folks in this journey. We are not ignoring that on purpose. I think that calling it in and recognizing that that's a part of the complexity of the moment, and that the monkeypox virus could impact any person, regardless of age, regardless of sexual orientation, gender identity. And we continue to urge the data and the way that data is tracked to further include all of the folks that this might be serving. I'll pause there if there are other comments from y'all, and then folks are curious about how kids are also impacted.
Rebby, thank you for that. It's so important. And I want to underscore, at the department, we really care about the accuracy and the precision of our data, so we can really understand how to really reach folks who we need to reach. We through COVID, really built out capabilities to understand folks that we're reaching, whether it's demographic data across race, ethnicity, gender identity, geography, and a number of other things, so we could really partner with the right folks who have trusted connections and communities, and really put our providers and our other partners kind of on notice for making sure they're reaching folks really proportionate with those that we need to be serving, that we're kind of experience these various health disparities as they play out. Right now on our website, and I think the link has been put in the chat a few times, we've been updating our demographic data of the current monkeypox cases every day. It gets put up about noon every day. I will, there you'll see gender, you'll see age, you'll see race, you'll see ethnicity. I will acknowledge that we have not been speaking specifically about sexual orientation from a count perspective, because we've tried to take into account the importance of privacy. This really matters also. This is another dynamic as part of this current outbreak. We qualitatively describe that on our website, reminding folks that nearly all cases have been in this population, in the MSM population. However, it's not, it's important that we don't give specific numbers when the numbers are so small. I don't want to I want people to make sure that there's a privacy element there. And I want to also just run with that for a moment and say, this is also really important to our providers. They have an oath of protecting privacy and a legal expectation. This is core work for our health departments. And so, getting a vaccine, doesn't mean that you fit into a particular group. It means that you're eligible because of one of the several reasons that you're eligible. I recognize this is complex, and I appreciate kind of naming that dynamic. And as the data changes and evolves, we're going to be incredibly transparent about that.
And Dr. Mobley, if I'm not mistaken, one of the earlier cases from maybe 1970 of the monkeypox virus occurred for a child, maybe a 9-month-old, if I'm not mistaken. Folks in the chat and the Q&A are really curious. School starting in a few weeks. What does this mean for us going back to school and how we protect our kiddos? And what age are our kids eligible for vaccines as well?
Yeah, so you're correct that first case was in a child. The 1970s, the initial case was in a child, and children, particularly young children, do have a higher risk of severe illness, including more lesions and other systems being involved. But one good news, at least today, we have not had any cases in individuals under the age of 18 in North Carolina. There may be one or two that have been reported in the US, but I don't know any specifics about them. Like Secretary Kinsley mentioned, since anyone can get monkeypox, yes, kids are at risk. And, the very things that we love to do with our little ones are what would put them at risk. We love to cuddle them. My 6-year-old still likes to climb into bed with me in the morning and cuddle. And so we, there is that concern. And so it's definitely worth being extra vigilant. But as far as schools are concerned, I mean, one, yeah, it's tough because kids roughhouse and play, but this is not a really transmissible virus. This is not like chickenpox, and you send a kid to school with chickenpox in the class, unless they've all been vaccinated, are going to come away with chickenpox. So I think it's I'm not concerned about school starting. I think the key message here is you have to know what symptoms to look out for, and if you or someone that develops a rash, go to your provider right away. Make sure that you kind of isolate yourself and keep others from coming into skin-to-skin contact with you until you've gotten checked out and diagnosed and treated if needed, and then do the same for your little ones. If they get an unexplained rash, that's what pediatricians live for, right? Parents calling about a rash. So get them checked out as soon as possible, and don't let fear of monkeypox interfere with your life in this way. I really think that we have the tools to diagnose, to prevent. And the question about vaccine and little ones, yes, the current vaccine is only licensed for 18 and over. There can be exceptions made for those under 18 years of age with additional paperwork. It's just, like a lot of our vaccines, the testing and all of the efficacy data was done in adults. It's not to say that it won't be effective in children, and there have been children during this outbreak who've been exposed and have been vaccinated successfully without any issues.
There have been a number of questions around the details of the vaccine as well as antivirals. So medicines like Valtrix or acyclovir typically for herpes. Are there other current new or current antivirals similar to those that could help treat or decrease symptoms? As well as, can you talk us through if there are different brands or different vaccines and the process that people can expect from a multi-dose, for example?
So on the antiviral front, the antivirals that we use to treat HSV will not work for monkeypox. There is a licensed drug. It's called tecovirimat, shortened name is TPOX, that is available. There are some steps that providers have to take to get the medication for their patients. The CDC, it comes from, I believe, a national stockpile that the CDC has, and they've recently decrease the burden of paperwork that has to be done in order to get the medication. And we actually do have medication here in North Carolina. There are certain clinics that already have it on hand in anticipation of seeing monkeypox patients. And we can certainly work with providers to get it very quickly if you see someone who is not doing well or is having increasing pain and would benefit from the medication. I missed the second part of your question. Oh, about the vaccine. Right. So there's two vaccines that are licensed for the prevention of monkeypox. The first one is the one that used to be given. It's called ACAM 2000, and nobody wants that. It was effective, but had a high side effect profile. The vaccine that we currently have available in North Carolina and in the U.S. It's called Jynneos. It is a live vaccine, but it's modified so that it doesn't replicate in human cells. So it's safer, has a much safer side effect profile. I think the most common side effects that are reported or adverse reactions that are reported are what we typically see with vaccines, which is a sore injection site, maybe some swelling and redness, but effective and highly tolerable is what we have available right now as far as vaccine.
Are there any known symptoms of the vaccine that folks need to be aware of?
So the one that I just mentioned is the main one. So the injection site pain, which, I think is pretty common with a lot of vaccines. I know I have had that with almost every vaccine I've ever received. Of course, anyone can have any reaction. Everybody's different. Everybody's body reacts differently. But if you've typically done well with other vaccines, there's no reason to suspect that you won't do well with this one. And if you want a full list of the side effect profiles that were reported during the trials leading up to the FDA approval of the Jynneos vaccine, we can certainly make that available in the chat.
There are just a few more questions here. So as folks if you have tuned in late, if there is a question that you would like to ask, feel free to. We've gone over a lot. This webinar is being recorded and will be available following the session. So feel free to share this with folks if they were not able to be present. Another question about surfaces. How long can monkeypox survive on surfaces, including furniture or doorknobs?
That is also a hard one. I mean, I don't know that I've seen data about this particular virus, but if it's a DNA virus, so they tend to be hardy. And if I liken it to another DNA virus that I know more about that on, like hepatitis B, it could be days. So, in the right climate, it could survive on fomites for quite a while. And so that's why it's important, particularly on items in your house that can't be easily washed, like a sofa, I forget what they're called when they have cloth sofa that you can't easily take off the cushion covers and wash them. That if you're isolating at home with monkeypox, cover it with a linen sheet, something that can cover the entire surface and then be easily removed and washed when needed.
Thank you for that. Another question here, are there plans to or discussions around providing financial support to patients with positive cases and dealing with a potential long isolation, as well as the income, the costs? I mean, we are still healing from the impacts of COVID. How might we be reaching people to support the long-term impacts of the virus?
That is absolutely something that we are considering. Right now we don't have the funding available to do that. During our COVID response, we're able to do isolation supports programming that we were really intentional about building into to serve folks that were most disproportionately impacted. But that is definitely something that we are considering. I think it's really important. We know how, as Dr. Mobley said, this can be very painful and debilitating, and folks would need to miss work as they isolate, and it can create real hardships for folks. And this is also why we need a more available health system and paid leave and all the other things that we need to really make it supportive for folks to be healthy. But we are trying to figure out every way that we can to support people. Yes.
Another question about what's happening at local health departments. Are our local health departments required to collect a Social Security number? It sounds like somebody who's attending had an experience in Johnston County where they were self-paying for a tuberculosis test and for a class. it might have been asked for their social security number in that process.
So social security number shouldn't be required in that situation. But if you'd like to follow up with us and we can, we can try to look into that. We'll put an email address or something in the chat to try to look into that.
And with that, there's some conversation around why there is a wait list for the current monkeypox vaccine, as well as the expansion of eligibility, maybe also helping folks be prepared where they're going in, either if it's for testing or for vaccination. What do they need to bring with them, and what should they not be expected to be asked for?
Great. So maybe I'll start, and then Dr. Mobley, kick it over to you. So as you go into the health department I'll kind of start with the end, you really don't need much. This is a free product. And so you don't need to, prove anything or provide anything. We're, going to take some information down around the administration. So we have data around race and ethnicity and other demographic information to make sure that we are serving people in an equitable way. But as far as residency status or any other thing, those are not questions that we are concerned with. On the first part about the wait list is, again, the supplies are incredibly limited coming into North Carolina right now. We are prioritizing the vaccine where it can do the most good. As Dr. Mobley mentioned, in the post-exposure prophylaxis, so individuals that have had close contact, getting them vaccinated to both hopefully remove the possibility of them getting an active infection, or at least really reducing the severity. And then also for those in communities that are most impacted right now, and again, the eligibility is men who have sex with men who in the last 90 days have either had more than one partner, have had an active STI, or are on PrEP. And so those are the communities that we currently seeing, or the groups and the cohorts we see it spreading the most in. And so really trying to wrap this out. Our goal is to contain and eradicate this virus. And we need to move quickly in the spaces where folks are impacted and leverage our most powerful tool, which is vaccines, to do that. Get folks tested, identify it, isolate, vaccinate. And so that's why we're having this conversation. I want everyone to spread that information and to work quickly, because we can eradicate this. This is very different from a respiratory illness like COVID. I hope it's clear it's not anywhere near in the same contagious profile. It's very different. You can be sitting next to someone at a restaurant, you're not worrying about monkeypox, but if we move quickly and we get more vaccine, which we continue to push for, we really can contain and eradicate, but we need everyone's help and focus. So Dr. Mobley, I know I went a little too long.
No, that you covered it all. I don't know if there's anything else to that question that needs to be answered.
I think maybe the one piece I missed was, if someone goes into a clinic setting to get tested, what can they expect?
It might depend on the clinic setting that you're in, but really what you should expect is a thorough physical exam. So, first your provider should take a really good history and talk to you about, where you've traveled, who you've been with, have you been around anybody who's had a rash that looks like, the pictures that we're displaying on monkeypox, or that they were actually diagnosed with monkeypox. What are your risk factors for having been exposed to it? And then a thorough physical exam, which in my world means taking it all off, because you can have lesions where you can't see unless you take off the shirt, you take off the pants, you take off the boxers, take off the shoes and the socks so I can see the bottom of your feet. But having that thorough exam to make sure that they get a good assessment, And then if there are lesions that are testable, to go ahead and do that testing. And the testing is actually, it's relatively non-invasive, though it's not comfortable. So it's, it's taking swabs and quite vigorously rubbing them over the lesions so that you can collect cells from your skin and hopefully the monkeypox virus as well to test. So how uncomfortable the testing is might depend on where the lesions are, but that's what you can expect. And then as far as the vaccine visit, I do want to mention the importance of them getting your information, not just your demographic information, like Secretary Kinsley said, because we definitely want to make sure that we're getting the vaccine out as equitably as possible to the populations that are being most impacted at this time. But getting your name, your contact information is going to be important for that second dose. So, we're prioritizing first doses right now to try to get as much vaccine out there. But remember, this is a 2-dose vaccine series, and you got to get that second dose and making sure that they have information to contact you to schedule that second dose, or if need be, and hopefully that's not the case, to reschedule if something comes up, is going to be important.
There has been lots of planning for how to get vaccinated, getting all of those multiples, and how to track. Are there any studies or information about any impacts of catching up on COVID vaccines and boosters while also getting vaccinated against monkeypox?
I haven't seen anything specific. I have seen some recommendations about around giving the 2 vaccines either at the same time or a little bit space, so you don't get one vaccine in one arm and then the other in the other, and have to deal with potential adverse reactions from both. But I think I would follow your healthcare provider's guidance on this. If they're trying to catch you up with COVID and also think you would benefit from a monkeypox vaccination and feel comfortable giving it to you on the same day or maybe a couple of days apart, I would trust them on this. Because they're really going to be in the best position to know what will work best for you.
I appreciate you both. This is an ongoing conversation. The more that we know, I'm sure we'll come back online and give that information to y'all, the public. If we did not have a chance to get to your questions this evening, please know that you can reach out to us. We'll drop a contact in the chat, as well as knowing that you can come to the NCDHHS website at any time, and you can find ways to reach us. I'd love to take a moment for any closing thoughts that we have and the commitments that we have moving forward to protect and heal our state, knowing that we've been through a lot in the past couple years, and that we are well equipped and suited to address this public health crisis. Dr. Mobley, we'll start with you and then go to Secretary Kinsley.
Sure. Well, I appreciate being invited to the town hall to have this discussion. I myself am a member of a historically marginalized population, and it's always great when I see public health and healthcare providers really reaching out to the communities most impacted by a slew of health conditions and really trying to get our take on it and how best they can support us. So I appreciate being a part of the discussion with you all, and I am absolutely available if any questions come up after this chat. Most people know how to reach me by email, but it's victoria.mobley@dhhs.nc.gov, and I'm happy to talk with anyone after this if anything comes up. Thank you.
I want to really start by saying thank you to everyone for taking the time. I want to, in particular, recognize that, in addition to being really weary from COVID, we're also dealing with unprecedented levels of mental health concerns and a lot of other issues that are really compounding. And I think, Rebbe, you made a very good point. We're all still healing in so many dimensions of that concept. I have a lot of hope in this moment. I think that it can be scary because we're kind of thinking about, oh my gosh, we're dealing with another outbreak of a new thing right after we've been through what has been this incredibly traumatic period of time. And I think, I go back to exactly where Dr. Mobley started at the beginning, which is, the hope is that we've got in this moment the tools and the knowledge about this virus, because this thing has been around for a very long time. Now, we don't know everything. It's definitely spreading in ways we've not seen it spread before. We talked about that as far as it kind of getting in particular cohorts. So the department remains committed to being very transparent about what we do know and what we don't know, and we're still learning, and we're going to continue to share that information as we go on. But we have such hope because we have testing, we have growing numbers of vaccines, we have some and growing numbers of antivirals to help support people who do get an infection. And in the end, this is going to come back to us all really continuing to work together to quarantine, to contain this virus, and to eradicate it. And I deeply, deeply appreciate everybody's shared commitments to the health of our communities. Thank you.
Thank you both for your time. And on behalf of Equality North Carolina, it's a joy and a pleasure to be able to do this work. We are in a very distressed moment, knowing that we continue to see attacks against LGBTQ people at the legislative level, on the ground, at polling locations, as well as, unfortunately, rising amounts of anti-trans violence. So to watch, hear, and witness the impacts at the public health level adds into the stressors. And so if you are here tonight, if you are LGBTQ and a part of this family, I just want to honor you and see you, and thank you for being here, and for all of those that continue to support our communities and help keep us alive, including our kids. Thank you for your dedicated work. Folks in the room tonight might have additional questions or even strategies. We've seen some great ideas about how to do targeted outreach on community apps or dating apps that might be serving the communities who might be most at risk. And this would be a great way for us to continue working with the Department of Health and Human Services. So I will also drop my email in the chat, as I'd love to dive in deeper into how we can honor each of these ideas as well. Friends, it's dinner time in this house. I hope that you have time and space to nourish, to hydrate, and find some rest. Once again, my name is Rebby Kern. It's a joy to be here with you, and hopefully we'll be tuning in back together super soon with updates as they come present in North Carolina. Thanks again, y'all. We'll see you soon.
Thank you.
Recording stopped.